presumptive antibiotic therapy and antibiotic treatment. Our source is surgical antibiotic prophylaxis and SWARCH also, and also the DOH guidelines on antibiotic prophylaxis. So when we say antibiotic prophylaxis, this is the administration of antibiotics prior to contamination of previously sterile tissues and fluids. What we mean of contamination is prior to incision, right? Because the act of incising the skin is also it's also just like introducing infection because of the normal flora in the skin. So we have antibiotic prophylaxis as one of the strategies to decrease the the infection, right? The infection rate post-operatively of the incision. Presumptive antibiotic therapy is the administration of an antibiotic when there is a strong but unproven established infection. Okay, the difference between antibiotic treatment is that the treatment is administration of the antibiotic when an established infection has been identified. So if you have an evidence of infection through culture, then you call that antibiotic treatment. When you just give antibiotics because of unproven established infection, you don't have culture, but you're just basing it on the microflora, normal flora of the area of the system that you're gonna operate. That is presumptive antibiotic therapy. So to define surgical site infection, so these are infections of the tissues, organs, or spaces exposed by the surgeon during surgery. So how does it develop? The development of surgical site infection depends on three factors: the degree of contamination, the duration of the procedure, and the factors that may affect, the host factors that may affect the formation of infection, just like diabetes. Or what factors we mean patient factors: diabetes, malnutrition, obesity, and immune suppression, such as in patients who are undergoing chemotherapy and patients with HIV/AIDS. And surgical site infections may be classified as superficial or deep. As for the incidence, is the most common nosocomial infection among surgical patients, followed by pneumonia and UTI, the third. The third most common nosocomial infection. SSI rates for any surgical procedure may be higher than traditionally reported because most surgeons or residents in training don't report surgical site infections. Recent studies show a range between 10 to 35%, although what's reported is really lower than that. 2/3 of the SSI are incisional, and 1/3 of the surgical site infections originate from the organ or spaces that are accessed during surgery. Studies would show that SSI would add 7.3 additional post-operative days, which would mean increased hospital care, hospital cost, right? Because of the 7.3 additional post-operative days. And not just that, it also would add to morbidity and mortality of the patients. Of course, cost would also go up with additional 7.3 post-operative days and more medications, more morbidities. And it also doubles the likelihood of deaths and ICU admission. So this is a table which describes what we had just discussed, right? The length, the increase in hospital stay, also the increase in hospital cost. That's from the WHO. As for superficial incisional SSIs, they may occur within 30 days, and they occur in the skin and subcutaneous tissues only. Compared to your deep SSI, they also occur within 30 days after the surgery or after the incision, and within 1 year if there are implants like mesh and your prosthesis. Okay, as they may act as foreign body, and they may produce infection in the fascia and in the muscle layers. While your organ and space SSIs, they occur within 30 days as well, within 1 year if you have implants placed, like stents, mesh, right, and other prostheses or valves in the heart. And one of the prime examples of organ or space SSI is intra-abdominal infection. So this is the wound classification in relation to bacterial load. As you can see, we have 4 classes of wounds classified as clean in class 1 and goes down to dirty, progresses to dirty wounds in class 4. You have to familiarize yourselves with this table. This is very important. You can find this in your book, Swartz Principles of Surgery, with each class corresponding with the corresponding expected infection rate. As you can see, that let's say, for example, colorectal surgery, a patient underwent colon resection, so that's considered clean contaminated class 2 wound with an expected SSI rate of about 4 to 14%, the highest among the classes. So patients undergoing trauma surgery, right? That's class 3, okay? Necrotizing soft tissue infections such as Fournier's gangrene, that's class 4. That's the considered dirty. But if you have elective surgeries such as breast surgery, hernia surgery, thyroid surgery, then that's clean, class 1, 1 to 2% only. Okay, so here are the risk factors for the development of surgical site infections. Just take a look at the slide in front of you. Patient factors, the factors are divided to 3: patient factors, local factors, and microbial factors. Patient factors being has the most number of being enumerated right there, such as anemia, radiation, obesity, old age. Okay, so in local factors, so these are the contribution of what type of surgery do you do, right? The contamination of instruments. If you gave adequate antibiotic treatment or prophylaxis rather, how long did it take you to do the surgery? So they are under the local factors. While microbial factors, prolonged hospitalization, type of antibiotics, type of microbes or bacteria, right, that's found in the wound, and if there's any resistance to antibiotics. So what are the prevention strategies, right? So we have 3: preoperative phase, intraoperative phase, and postoperative phase. So these are strategies to prevent SSI. So as for the preoperative phase, we have showering, hair removal. For those of you who have been exposed to the wards or to the floor in your college days, then you notice that patients who will undergo surgery, they do the shaving, right, of the area where the incision will be made. Hair removal, mechanical bowel preparation for colon and rectal surgery, hand decontamination of the surgeon's pre-op, and of course, what's important is the perioperative glucose control, because if you cannot be able to control the glucose levels perioperatively, then that would also cause increased rate of infection, especially in diabetic patients. And very important is antibiotic prophylaxis. So these are taken from the WHO guidelines on safe surgery. Right, for the intraoperative phase, we have antiseptic skin preparation done after induction. Maintaining patient homeostasis is also important. That's especially in pediatric patients. Thermoregulation should be kept. Temperatures should be kept between 36 to 38 degrees centigrade. And here comes the technique on how we do surgery. It's emphasized here that there should be a meticulous surgical technique, which includes general or gentle handling of tissues and avoid fecal spillage when dealing with bowel injury or bowel perforation. Okay, so the role of the surgeon has a big role to play also in the prevention of SSI. Wound irrigation and intracavitar lavage. It's recommended that we use at least 1 liter of NSS when we do wound irrigation or intracavitar lavage. Operative time, what is acceptable is less than 3 hours. More than 3 hours, we consider that a long OR. So more than 3 hours, the increased risk of developing SSI. Less than 3 hours, the risk is minimal. Antiseptics and antimicrobial agents prior to wound closure can be also given before or to prevent SSI formation. Again, perioperative glucose control is there. Post-operative phase, course, your wound dressing every 1 to 2 to 3 days, depending on how clean the wound is. Topical antimicrobial agents, although these are not given routinely, but you can give them as well. Thermoregulation is also recommended. Maintain the temperature between 36 to 38 degrees centigrade. And of course, cannot overemphasize the fact that you have to control your glucose levels to less than 200 milligrams per DL. That's a common question in surgical exams and in the board exam. The level of glucose that's recommended perioperatively, 200, less than 200 milligrams per DL. So let's now go to antimicrobial prophylaxis. So as for the general principles of this antimicrobial prophylaxis, the final decision regarding the benefits and risks of antibiotic prophylaxis for an individual patient will depend on the following. The patient's risk for surgical site infection. So you have to look at the risk factors. Is patient diabetic, or is your patient having AIDS, all right, HIV, the potential severity of the consequences of surgical site infection. This patient have some comorbidities that will increase with the presence of SSI. You have to ask that question as well. The effectiveness of prophylaxis in that operation. Do we really need to have prophylaxis even though in clean surgeries? You have to ask that as well. And the consequences of prophylaxis for that patient. Because in some patients, when you give prophylaxis, some patients would form Clostridium difficile colitis. So you have to weigh the benefits and the risks of giving antibiotic prophylaxis. But if you should give prophylaxis, it should start preoperatively or be given preoperatively, ideally within 30 minutes of the induction of anesthesia and within 1 hour of the surgical incision. More general principles of giving antibiotic prophylaxis. When you have a long surgery, an additional dose of prophylactic antibiotic during the operation is indicated if there is a major blood loss of more than 1,500 ml during surgery. Okay, some surgeons would give additional dose sa 700 cc blood loss pa lang. But the principle is, the recommendation is 1,500. Hemodilution of up to 15 ml per kilogram. And if your surgery has lasted for more than 4 hours, it's imperative that you give a second dose or an intraoperative dose of antibiotic prophylaxis. It's still considered prophylaxis, an intraoperative dose. Usually half the dose. We will be discussing that later towards the end of this lecture. Okay, so 4 hours. So these rules apply with the exception of teicoplanin, gentamicin, and ciprofloxacin, where additional doses are not required. When you give these 3 antibiotics preoperatively, you don't need to give additional doses of these antibiotics, as these antibiotics are not stored in the bloodstream, they are stored in the tissues, right? So it's not affected, their levels are not affected by blood loss or by the length of surgery. So remember that, teicoplanin, gentamicin, and ciprofloxacin. It's also worth knowing that antibiotic prophylaxis is not a substitute for the proper observance of aseptic and aseptic techniques, good surgical technique, and gentle handling of tissues, and good clinical judgment. So it doesn't mean to say that mapawarak na lang ang surgeon sa opera, no? Kay total naka-antibiotics man. So no. You still have to do your aseptic technique because that's important, and it will really decrease the occurrence of your SSIs, especially good surgical technique and gentle handling of tissues, and of course, good clinical judgment. So does antibiotic prophylaxis really work? So this table is a conglomeration of studies, right, from the WHO. The numbers needed to treat. So the lower the number needed to treat, right, the more effective antibiotic prophylaxis is. So it's effective in colon surgery, right? It's high in total joint replacement. So you may or you may not give antibiotic prophylaxis in vascular procedures, right? But you should give prophylaxis in those systems with a low numbers needed to treat, like colon, cardiac, hysterectomy, Okay, breast and hernia, it's 58, so it's a clean surgery. So you may or you may not give antibiotic prophylaxis depending on the policy of the institution and depending also on the antibiogram. So what is an ideal prophylactic agent? An ideal prophylactic agent prevents SSI. It could prevent mortality and morbidity, or it could decrease SSI-related mortality and morbidity. It can reduce the duration and cost of healthcare by preventing primarily SSI. It has no or least amount of adverse effects, have no adverse consequences on the microbial flora, all right, to cause Clostridium difficile colitis or on the patient or the hospital. And lastly, it should have a narrow spectrum of activity. So therefore, you should first determine what type of microorganisms or normal flora that you will deal with. Like if you're going to operate on the gallbladder, so that's part of the digestive system. So your normal flora should be your microbes that are found in your digestive system, such as your E. coli and your the rest. No, so your antibiotic prophylaxis should focus on your E. coli and your organisms within the intestines or the gastrointestinal system. For pediatric patients, the principles mirror those for antibiotic prophylaxis in adults. However, data in pediatric population are limited, okay? And it has been just extrapolated from adults. For clean surgeries, the general rule is no prophylaxis is recommended. For the exception, no, if you use prostheses, implants, or you do cardiac surgeries, you have to give prophylaxis even in pediatric patients. Recommendations are generally the same as for adults, except that you have to adjust your dosing based on the weight of the patient. Fluoroquinolones should not be used because of toxicity to pedia patients. So what are the recommended antibiotic prophylactic agents by surgical procedure? So for cardiovascular surgery, then you have cefazolin, cefuroxime. If allergic to both, then you can give vancomycin. And some surgeons are giving intranasal mupirocin as well. So you have the dosage right there. So included in cardiovascular surgery, you have surgery for the abdominal aorta, leg vascular procedures that involve groin incisions. So these are vascular procedures. Any vascular procedure with insertion of prosthesis or grafts, lower extremity amputation, cardiac surgery, pacemaker placement, your heart transplant, implanted cardiac defibrillators, so on and so forth. Now for gastroduodenal and biliary surgery, you can give cefazolin, ceftriaxone, right? Or you can give cefazolin, okay, ciprofloxacin, piperazoline. Surgery included in this group, we have percutaneous gastrostomy, Whipple procedure, lap chole. Okay, although this low risk, you don't have to give your prophylaxis for laparoscopic cholecystectomy. Biliary surgery, again, high risk laparoscopic cholecystectomy, then you have to give your cefazolin. So what do you mean when you have low risk lap chole? Okay, patients who have cholecystitis, so that's high risk. Diabetic patients, high risk. Okay, pag low risk, otherwise, no, asymptomatic gallbladder disease, then they're considered low risk. Patients, young patients with no comorbidities, then that's considered low risk. ERCP, endoscopic retrograde cholangiopancreatography, you can give ciprofloxacin and piperacillin. More on gastroduodenal and biliary surgery, like PEG placements, okay, in high-risk patients, okay, you should give prophylaxis as well. Ceftriaxone could be used, okay, in centers where there's increasing resistance to Enterobacteriaceae, to first and second generation cephalosporins, because we usually give cefazolin or cefoxitin. Avoid using ceftriaxone in neonates because of the toxicity as well. Biliary high-risk factors, as I've mentioned earlier, elderly, diabetes, immune suppression, patients with an evidence of acute cholecystitis, such as your Murphy sign and thickened wall, pregnancy, non-functioning gallbladder, patients with jaundice or common duct stones, they're considered high risk as well, or anticipated bile spillage in patients with obstructed stone, right, or high drops of the gallbladder. And if you anticipate a longer surgery, more than 2 to 3 hours, then you have to give your prophylaxis as well. For colorectal surgery, so that's obvious, you should give your antibiotics. You can use cefazolin plus metronidazole with the following dosage there: cefoxitin and ceftriaxone plus metro or ampicillin sulbactam. Now, if you have allergy to those drugs, then you can use clindamycin plus gentamicin or aztreonam, then also ciprofloxacin. More on colorectal surgery, you can use cefazolin for your small bowel surgery without obstruction. Okay. Then you can add metronidazole if obstructed. Pwede mo lang na timpla-timplahon. Appendectomy for uncomplicated appendicitis, then you have options to give cefoxitin, cefazolin, and metronidazole. For head and neck surgeries, you can use cefazolin, 2 grams IV plus metronidazole or clindamycin as well, plus with or without gentamicin. For neurologic surgery, you can give your cefazolin, vancomycin, clindamycin for clean and elective craniotomies. While you're contaminated clean, when you have to cross your sinuses or deal with your nasal and oropharynx, then you can give clindamycin, ampicillin sulbactam, cefuroxime, and metronidazole. If you're doing CSF shunt, right, or intrathecal pumps placement or deployment, then your first line of prophylaxis should be cefazolin. Then go to vancomycin if it's not available, if you have allergies, or clindamycin could be used as well. Okay, for OB-GYN surgeries, for vaginal or abdominal hysterectomy, first line of prophylaxis should be cefazolin or cefoxitin with the following dosage. Just check on the slide. Or you can give ampicillin sulbactam. And if allergic to those drugs, then you can give clindamycin plus gentamicin. For CS, you can give cefazolin as your first line, and second line is clindamycin plus gentamicin. And if you perform episiotomy after normal vaginal delivery, no antibiotic prophylaxis is recommended. For ophtha surgery, then you can give neomycin, polymyxin B, or fluoroquinolone. But this is pegged as optional at the end of the procedure. But you can also give cefazolin, right? Subconjunctival injection or intracameral injection of cefazolin as well. Or you can use cefuroxime. For orthopedic procedures like total joint replacement, spinal procedure, hip fracture repair, of ORIF, okay, placements of screws, nails, plates, and wires, your first line is cefazolin, vancomycin as your second line, or you can give clindamycin as well. Again, some surgeons would give intranasal mupirocin. Clean operations of hands, okay, prophylaxis is not indicated. Okay, hands, feet, arthroscopy without implantation of foreign materials such as grafts or screws, right? They are considered clean, so no prophylaxis is needed. For thoracic surgery, non-cardiac procedures, right? If you have the surgery for the lungs, like your VATS, okay, thoracoscopy rather, including lobectomy, pneumonectomy, lung resection, okay, thoracotomy, video assisted thoracoscopic surgery, that's your VATS. You can use cefazolin, ampicillin sulbactam with clindamycin. And for Euro procedures, if you do cystoscopy, prophylaxis is not necessarily indicated if urine is sterile. So you can You determine that by urinalysis. You may give also a dose of fluoroquinolone or cotrimoxazole for those patients with advanced age, immunocompromised, and anatomic abnormalities. But first, you have to treat patients with UTI based on urine or urine culture and sensitivity prior to your cystoscopy. But if you plan to do manipulation during your cystoscopy, you have to give ciprofloxacin prior to OR, or you can also give levofloxacin. For transrectal prostate biopsy, you can give ciprofloxacin as well. For breast and hernia surgery, as I've mentioned earlier, you need not to give prophylactic antibiotics. But should you give prophylactic antibiotics, then you could consider giving cefazolin or ampicillin sulbactam or clindamycin. Okay, so this was what I was mentioning earlier, that uh, in the middle of the surgery, right? If in prolonged surgery, you can give an intra-op dose of your antibiotics. Okay, this is based on the half-life. All right, or like let's say for example, if you gave preoperatively 2 grams of cefoxitin. Okay, so your dose is about 40 milligrams per kilogram for pediatrics. For adults, you can give 2 grams pre-op. Its normal half-life is 0.7 to 1.1 hours. So therefore, 2 hours into the surgery, you should give a half dose of cefoxitin. Right? So if you give 2 grams pre-op, you give 1 gram after 2 hours. Right? So ciprofloxacin, although its half-life is about 3 to 7 hours, you don't need to give an intraoperative dose. Those were the exemptions that I have mentioned earlier, like for your fluconazole, gentamicin, metronidazole, because these antibiotics are stored in the tissues rather than in the bloodstream. Okay, erythromycin, metronidazole, and neomycin, no need for intraoperative dose. So lastly, the surgeons should have to be re-educated. Okay, all of us, not just the surgeons, because we have to be careful in using our antibiotics. We don't want to develop we don't want our the microbes, the bacteria to develop resistance to our antibiotics. So the surgeons have to be re-educated regarding antibiotic prophylaxis. The surgeons, or everybody, all healthcare workers, should have to participate in achieving a consensus with specialists, physicians, antibiotic policymakers, and representatives of health organizations before implementing new guidelines. So there should be training before implementing new guidelines, lecture series. Some hospitals are doing this. Effective surgical site infection surveillance systems or programs should be done, right? Proper reporting, okay, as well as antibiotic utilization reviews. These should be established in every clinic, between hospitals, and also in a national level. That's why the DOH is really keen, right, in implementing this policy. The professional societies and hospital administrators also have to intervene in physicians' practices, because some physicians they just use antibiotics for the heck of using antibiotics because of one reason for another without any basis at all. So the administrators could intervene in such practices. So management of surgical site infections. How do you manage surgical site infections if it really happens? Because we have discussed earlier how to prevent, but what if it happens? So first is, and the most important is, the source control, or the drainage of all purulent material through debridement of the vitalized tissue and or removal of the foreign bodies that were deployed at the site of infection, plus antibiotics or remediation of the underlying cause of infection. If it is perforation, then you have to repair. Abscess, you can drain abscess via percutaneous drain insertion or incision and drainage. Bowel preparation, expedient surgery to repair perforation. Okay, you should do stap surgery, stap XLAP if you have perforation of your bowel, or leaks, or anastomotic leaks for that matter. Necrotizing soft tissue infection, that would require expedient debridement of necrotic tissue. because any delay in operative intervention, whether due to misdiagnosis or denial of the surgeon or the need for additional diagnostic studies, which is not needed in these cases, a delay is associated with increased morbidity and occasional mortality. So you don't want that to happen in your patients. Always review the institution's antibiogram. In the antibiogram, you can find the most common isolates, the growth patterns of the microbes, the resistance patterns as well, and the sensitivity patterns of bacteria. Treatment should be or always evidence-based, based on culture and sensitivity, if not based on the antibiogram that is being provided by the institution where you're working, where you will be working. Antibiotic treatment for surgical infection, empiric therapy, usually it's only 3 to 5 days or even less, and it should be curtailed if the presence of local infection or systemic infection is not revealed, or the absence of fever, or the absence of pain and redness. Standard guidelines in the treatment of monomicrobial infections. So for UTI, you have 3 to 5 days of antibiotics. For pneumonia, you have 7 to 10 days, and bacteremia, 7 to 14 days. For polymicrobial infections, gangrenous appendicitis, one example, you should treat the infection. You give antibiotics for 3 to 5 days, 5 to 7 days of therapy for treatment of peritoneal soilage due to perforated viscous, moderate degrees of contamination, and 7 to 14 days of therapy for extensive peritoneal soilage or feculent peritonitis, or that occurring in the immunosuppressed or immunocompromised host. When do we discontinue antibiotics? Of course, when you repeat your CBC and you noted that your WBC count is normal from high, no, from an elevated state, it becomes normal after your antibiotic treatment, lack of band forms, lack of fever, and no evidence of your SIRS or your systemic inflammatory response syndrome. So you just have to review the components of SIRS. When do you consider the patient of having SIRS? So that's all in your books, because these provide close to complete assurance that infection has already been eradicated. So thank you. That's for our first lecture. Any questions while I prepare for the next slide? Questions, ladies and gentlemen?
I think none na, Doc.
You think none? Ako na lang ma-question? Pati ka. So just review, ha? Read your books. Your exam will be based on the contents of Swartz, your books, and the lecture. The things that I've emphasized, especially the tables right there. And SIRS, okay? We'll be asking questions on SIRS. So you can read on that. So let's proceed to the next lecture. Wait lang, ah. Can you see my slide?
Yes, Doc.
Okay, so this time we'll be discussing wound healing. Okay. So let's touch a little bit on the history of wound healing, and let's give credit to those people who studied wound healing in the early days, right? So it actually started in the 2000 BC. Okay, the Sumerians. So they had a spiritual method of incantations, physical method of applying poultice to the wound, then followed by the Egyptians in the 1550 BC. They were the first to differentiate between infected and diseased wounds, right? Non-infectious wounds. Then the Greeks, they went even further and classified wounds as chronic or acute. This was the time when you have your Roman gladiators, okay? When they had enormous number of wounds to deal with following combats. And they emphasized the importance of maintaining moist environments to ensure adequate wound healing. Okay, then Ignaz Philipp Semmelweis, a Hungarian obstetrician, he noted that the incidence of puerperal fever was much lower if medical students, just like you guys, following cadaveric dissection, okay, wash their hands with soap and hypochlorite. So do you wash your hands? Probably before they were not using gloves. Okay, so Louis Pasteur was instrumental in dispelling the theory of spontaneous generation of germs, and provided that he exposed that germs existed in and were always introduced from the environment. So a big contribution by Louis Pasteur. And Joseph Lister, all right? He noted that some areas of the city sewer system were less murky than the rest. That was his term. And discovered that water from pipes that were dumping waste containing carbolic acid. Okay, so he cultured those samples from their sewerage systems. Okay, and Robert Wood. Okay, he also did some research and production of antiseptic dressing in the form of cotton gauze impregnated with iodoform. So iodine, no? So Robert Wood Johnson. Since then, several other materials have been used, right, to clean our wound that can also be used to impregnate cotton gauze and to achieve antisepsis. Currently, the practice of wound healing encompasses manipulation, use of, and among others, inflammatory cytokines, growth factors, and bioengineered tissues. It is the combination of all these modalities that enable optimal wound healing. So to start our discussion, the main point of our discussion this afternoon, then we touch about our anatomy of the skin, since this is the area that we are concerned about, especially in wound healing. So our epidermis, composed of several thin layers, you have it right there in your slide, and the several thin layers of epidermis containing the following, okay? It contains your melanocytes, which produces melanin. We know that that's a pigment that gives color to the skin, and keratinocytes, which produce keratin, of course. And this is a water repellent protein that gives the epidermis its tough and protective quality. While your dermis is composed of a thick layer of skin that contains collagen. Okay, it is here also where you can find your elastic fibers, your nerves, your blood vessels, your sweat and sweat glands, your sebaceous glands, and your hair follicles as well. While your subcutaneous tissue, this is a layer of fat underneath the dermis and contains also blood vessels, the bigger blood vessels, the nerves, the lymph nodes, okay, and loose connective tissues that are filled with fat. Now, here is your classification of your wounds, right? So you have clean wounds, right? Your clean contaminated, just what we had discussed earlier, right? Your infected and your contaminated wounds. So I don't need to discuss that again. So wounds are classified as either acute or chronic, okay? As for your acute wounds, they heal in predictable manner and time frame. Okay, the process occurs within few, if any, with few or if any complications, and the end result is a well-healed wound. So that's healing by primary intention. Surgical wounds can heal in several ways. an incised wound that is clean and closed by sutures, then we call that healing by primary intention. Often because of bacterial contamination or tissue loss, a wound could be left open to heal by granulation tissue. So you don't have to close infected wounds, just wait for it to heal by granulation. And granulation tissue formation and contraction. So this constitutes healing by secondary intention, as you can see in your slide right there. Delayed primary closure or healing by tertiary intention represents a combination of the first two classifications, consisting of placement of sutures and allowing the wound to stay open for a few days, right? Or the vice versa, the other way around. You allow it first to dry up within 2 to 3 days, then on the 4th day, you can suture up your wound, okay? Close it with sutures. The healing spectrum of acute wounds is broad. You can review your books on that. In examining the acquisition of mechanical integrity and strength during healing, the normal process is characterized by a constant and continual increase, okay, that reaches a plateau at some point post-injury. So it's a gradual increase in strength. Wounds with delayed healing are characterized by decreased wound breaking strength in comparison to wounds that heal at a normal rate. Okay, you would notice that in patients with SSIs, right, with infection, when the wound has a delayed rate of healing, no, they would their healing is not as strong as the wounds that heal normally. However, they eventually achieve the same integrity and strength as wounds that heal normally, but on a longer period of time. Conditions such as nutritional deficiencies, okay, infections or severe trauma cause delayed wound healing, which reverts to normal with correction of the underlying pathophysiology. Impaired healing is characterized by a failure to achieve mechanical strength equivalent to normally healing wounds. Inflammation occurs, right? So these are the stages of your wound healing, okay? Hemostasis, inflammation, then followed by your proliferation, and then maturation and remodeling. So after inflammation, the damaged endothelial cells release cytokines that increase expression of your circulating lymphocytes. Then you have histamine, your serotonins and kinins. They will cause vessel contraction and decrease in blood loss, no, after the act of wounding or incising. And these act as chemotatic factors for neutrophils that would proceed to the site of injury. The most abundant cells in the initial 24-hour period. For your proliferative phase, sorry, after your inflammation or hemostasis, so these are the presence of neutrophils, right? They have removed cellular debris and released further cytokines acting as attracting agents for macrophages. Then you have fibroblasts. Okay, they now migrate into the wound after your neutrophils and secrete collagen type 3. That begins the process of wound healing, okay, or maturation or remodeling. And angiogenesis occurs by 48 hours. The secretion of collagen, macrophage remodeling, and secretion and angiogenesis continues for about 3 weeks. The greatest increase in wound strength occurs in this phase. While in your maturation phase, the final phase, which is the final phase, this starts from 3 weeks onward and may last up to 9 to 12 months. Okay, so that's how long a wound can heal completely. This is where your collagen 3 is converted to your collagen 1, and there's an increase in tensile strength up to 80% of the normal tissue. Your PMNs also release proteases such as your collagenases, which participate in matrix and ground substance degradation in the early phase of wound healing. Now, the second population of inflammatory cells that invades the wound consists of your macrophages after your PMNs, which are recognized as being essential to successful healing. Okay, they're derived from circulating monocytes. Macrophages achieve significant numbers in the wound by 2 to 3 days, right? They peak at 3 days or 4 days post-injury, and they will remain present in the wound until healing is complete. So macrophages, just like your neutrophils, participate in debridement of the wound. So they clean the wound from foreign organisms. They do this by phagocytosis and contribute to microbial stasis by providing oxygen radicals and nitric oxide synthesis. The macrophages' most pivotal function is activation and recruitment of other cells via your mediators and cytokines, and growth factors as well as directly by cell-to-cell interaction and by intercellular adhesions, or your ICAM. By releasing such mediators as your TGF-beta, your vascular endothelial growth factors, your insulin-like growth factor, so on and so forth, as you can see there. And macrophages also play a significant role in regulating angiogenesis, or your growth of new blood vessels, which could help speed up the healing process, and as well as matrix deposition and remodeling. Your T lymphocytes comprise another population of inflammatory or immune cells that goes to the wound after your PMNs and your macrophages. Although they're less numerous than macrophages, T lymphocytes numbers peak at about 1 week post-injury, right? So earliest PMNs, about 24 to 48 hours, followed by macrophages until the 4th day, and your T lymphocytes about 1 week from injury, because they will bridge the transition from the inflammatory phase to the proliferative phase of healing. Okay, so just review your tables right there. We have, I've mentioned almost all of these earlier. And your next is your proliferation, right? After in the presence of your T lymphocytes. So the proliferative phase is the second phase of wound healing, okay, after the inflammatory phase. And this roughly spans about 4 to 12 days after the injury. Now, it is during this phase that there's a continuous growth of tissues, right? Tissue continuity will be established. Fibroblasts and endothelial cells are the last cell population to infiltrate the healing wound after your T lymphocytes. And the strongest chemotactic factor of fibroblasts is your PDGF, your platelet-derived growth factor. Additionally, lactate, which accumulates in significant amounts in the wound environment over time, is a potential regulator of collagen synthesis. Now, through a mechanism involving your ADP, or your adenosine diphosphate, these cells participate in formation of new capillaries, as we have mentioned earlier, or your angiogenesis, a process that is essential to successful wound healing, because without additional blood vessels, your wound healing will not succeed, okay, as expected. Endothelial cells migrate from intact venules close to the wound. Now, after their migration, there will be replication, and new capillary tubule formation is under the influence of such cytokines. This happens in the presence of cytokines and growth factors. Matrix synthesis, or the biochemistry of collagen. Collagen is the most abundant protein in the body, as these collagen material plays a critical role in the successful completion of adult wound healing. It's vital in wound healing. Its deposition, maturation of your collagen, and the subsequent remodeling are essential to the functional integrity of the wound. So type 1 collagen is the major component of extracellular matrix in the skin, while your type 3, which is also normally present in the skin, becomes more prominent and important during the repair process. So you should be differentiating that between the two. So for maturation and remodeling, the maturation and remodeling of the scar begins during the fibroblastic phase and is characterized by recognition of previously synthesized collagen. Collagen is broken down by your MMPs or matrix metalloproteinases. And the net wound collagen content is the result of a balance between your collagenolisis and your collagen synthesis, because when you synthesize collagen, there should also be lysis. That's important in remodeling, or else you will have your keloid formation. Wound strength and mechanical integrity in the fresh wound are determined by both quantity and quality of your newly deposited collagen. The deposition of matrix at the wound site follows a characteristic pattern, which is fibronectin and collagen type 3 constitutes the early matrix scaffolding. Your glycosaminoglycans and proteoglycans represent the next significant matrix components. And your collagen type 1 is the final matrix that will be present in the wound. By several weeks post-injury, the amount of collagen in the wound reaches a plateau, but the tensile strength continues to increase, right, for several more months, as we have mentioned earlier, even up to 12 months. Okay, fibrin formation and fibril cross-linking result in decreased collagen solubility, increased strength, and increased resistance to enzymatic degradation of the collagen matrix. Fibrillin, a glycoprotein secreted by fibroblasts, is essential for the formation of elastic fibers found in connective tissues. Now, scar remodeling, right, constitutes or continues for up to 6 to 12 months post-injury, gradually resulting in a mature, avascular, and a cellular scar, okay, depending on your genes, right? The mechanical strength of the scar never achieves that of the uninjured tissue. It will approach 80 to 90%, but not really 100%. Epithelialization, while tissue integrity and strength are being reestablished, the external barrier must also be restored. This process is characterized primarily by proliferation and migration of epithelial cells adjacent to the wound. This process begins during the first day of injury, right? And is seen as thickening of the epidermis at the wound. Now, all of us also have seen this, okay, have a personal experience with this, thickening of the epidermis around the wound. So that is reepithelialization. Marginal basal cells at the edge of the wound lose their firm attachments to the underlying dermis, enlarge and begin to migrate across the surface of the provisional matrix. Then you have a zone near the cut edge, which undergo a rapid mitotic division, and these cells appear to migrate by moving over one another in a leapfrog fashion until the defect is covered. So some of you have noticed that. Then you'd have wound contraction. All wounds undergo some degree of contraction. For wounds that do not have surgically approximated edges, then contraction will be really visible or obvious. The area of the wound will be decreased by this action. This also happens when we apply healing by secondary intention to infected wounds. So there's shortening, right, of the scar, which could result to contracture. Okay, so the next few slides will just describe several diseases, all right, that can affect heritable diseases that can affect the wound healing process of our body. First is your EDS, your Ehlers-Danlos syndrome. Okay, there's a defect in collagen formation. Then you have the Marfan syndrome, right? So these patients have tall structure, arachnodactyly, lax ligaments, right? So beware in these patients. Okay, they would have a poorer wound healing, and patients as well with osteogenesis imperfecta and epidermolysis bullosa. These are all heritable diseases. And lastly, acrodermatitis enteropathica. For a while, I have to answer this call. Okay, sorry about that. So let's continue. So healing in specific tissues, right? As for the gastrointestinal tract, they heal in a different manner compared to your skin. Healing of full thickness injury of the GI tract remains an unresolved clinical issue, right? Because healing of full thickness begins with a surgical or mechanical reapposition, or what we call anastomosis. Okay, you oppose the ends of the bowel after you cut it, which is most often the initial step in the repair process. Sutures or staples are primarily used. You can use sutures by hand, or you can use staples. Various other means such as buttons, plastic tubes, and various wrappings could also be used, right? But the failure of healing is unique, no? Uh, when you repair your bowel, right? When you do anastomosis, because failure of healing results to dehiscence, leaks, and fistulas, which carry significant morbidity and mortality, wherein you have to treat the infection and to repair the leak, right? By reoperating, doing another surgery on the patient, which would add morbidity and sometimes mortality. Conversely, excessive healing can be just as troublesome because it could result to your stricture formation or stenosis. So repair of the GI tract is vital to restoring the integrity of the luminal structure and to the resumption of motor, absorptive, and barrier functions. Wait lang ha. Kasadya. Sorry kay may introp referral ang isa ka consultant. Uh, wala signal sa OR. Mangita siya na signal. Anyway, continue. Di na to. Okay, gastrointestinal tract. Okay, so because during bowel injury or after resection, you have to anastomose and to establish the continuity of your bowel. And sometimes you don't get to, you have leaks, no? When your bowel repair does not, is not successful. What about the bone? Okay, healing in specific tissues, especially in the bone. So the initial stage of hematoma formation happens. This consists of accumulation of blood at the fracture site, which also contains the vitalized and soft tissue, dead bone, and necrotic marrow. Oh, dali na lang gid, dali na lang gid. I have to answer this call. angiogenesis. There's no revascularization in cartilage healing. Additionally, the hypervascular perichondrium contributes substantially to the nutrition of the cartilage. Therefore, injuries to cartilage may be associated with permanent defects. Okay, so it has to be replaced sometimes with grafts due to meager and tenuous blood supply in the area. The healing response of cartilage depends on the depth of injury. In a superficial injury, there's a disruption of the proteoglycan matrix and injury to the chondrocytes. There is no inflammation that takes place, right? There's no inflammatory response, but there is rather an increase in synthesis of your proteoglycan and collagen dependent entirely on the chondrocyte. But unfortunately, the healing power of cartilage is often inadequate, and overall regeneration is incomplete. Therefore, superficial cartilage injuries are slow to heal and often result in persistent structural defects. Okay, so in sports injuries, they have to be replaced. Okay, there are grafts that are being placed in the knees to replace these torn cartilages. As for your tendons and ligaments are specialized structures that link muscle and bone, and bone respectively. So tendon, bone to bone, muscle to bone is your ligaments, or vice versa. Yeah, they consist of parallel bundles of collagen interspersed with spindle cells. Tendons and ligaments can be subjected to a variety of injuries, right? Such as laceration, more on sports injuries as well, rupture, contusion, okay, mobility injuries, and underlying bone or muscles, that damages in these bones or muscles, and damage ends. Usually they separate, no? Separation of tendon, all right, and your bone and your cartilages and your ligaments as well. Tendons and ligament healing progresses in a similar fashion as in other areas of the body through hematoma, organization, laying down of your reparative tissues, and lastly, your scar formation. Again, type 2 and 3 collagen are vital in this process. As for your nerves, although early fetal healing is characterized by the absence of scarring and resembles tissue regeneration, there's a phase of transition during gestational life when a more adult-like healing pattern emerges. This is called the transition wound. This occurs at the beginning of the 3rd trimester. And during this period, there is scarless, however, the loss of ability to regenerate skin appendages. Okay, so in your nerve, you have Wallerian degeneration and neuropraxia, axonotmesis and neurotmesis. So it's also difficult to produce, all right, to expect your nerves to heal. In fact, when you have incisions in your abdomen which cut the nerves, then the skin surrounding the incision would be feeling numb. Right? For your fetal wound healing, this proceeds without fibrous or scar formation in contrast to adult wound healing. The mechanisms responsible for this process is in part because of the fetal wound has increased the content of your extracellular matrix, rich in hyaluronic acid. So proposed contributing factors to scarless healing in fetal wounds are the presence of fewer neutrophils, fewer inflammatory cells, like fewer monocytes, and also a shorter inflammatory period, and different concentrations, lower concentrations of cytokines, and a greater proportion of type 3 collagen in contrast to adult wounds. That's why your fetal wound healing is usually scarless. What about your chronic wounds? So these are defined as wounds that have failed to proceed through the orderly process that produces satisfactory anatomic and functional integrity. So you have examples right there, your skin ulcers, your Marjolin's ulcers, which becomes malignant in the future, your ischemic arterial ulcers, your venous stasis ulcers, your diabetic wounds are also considered your chronic wounds, and your decubitus and pressure sores. Okay, so these are the stages of your diabetic foot ulcers. So stage 1, then you have just redness and warmth of your diabetic wound. Then there's a shallow ulcer with distinct edges. That's stage 2. Full thickness or loss of skin. That's stage 3. And involvement of the fascia, connective tissue, muscle, and bone. That's stage 4. And the area covered with black eschar or the scab, then that's stage 5. Okay, so for diabetic wounds, you have to do your debridement, right, regularly. And sometimes it would require amputation if you cannot control it locally. As for your hypertrophic scars and keloids, the natural response to injury involves several stages of wound healing. Okay, we have discussed that earlier until the state of maturation. Okay, but sometimes you have hypertrophy and keloid formation as a sign of an overactive response to the natural process of wound healing. Sometimes you give steroids to stop this overactivity of healing. There, so excessive healing, the characteristics or difference between keloid and hypertrophic scars. Just review this table, right? And the treatment of wounds. Management of acute wounds begins with obtaining a careful history of the events surrounding the injury, then followed by a meticulous examination of the wound. You should assess the depth, the configuration, the extent of non-viable tissues, or the presence or absence of foreign bodies and other contaminants. Now, this may require the irrigation, right? During the examination process, it may require irrigation and debridement of the edges of the wound. And this is facilitated by using your local anesthesia because this would be really painful. Antibiotic administration and tetanus prophylaxis may be needed. So remember this process, no? As you will be rotating in the emergency room and you will be treating these types of wounds. So examination, debridement, right? After debridement, you give your antibiotics and your tetanus prophylaxis. And then you plan the type and timing of wound repair. So if it's clean enough, then you could do your suturing. If not, then you do your secondary intention or tertiary intention for that matter. Okay? Do not use epinephrine, right? For wounds of the fingers, toes, ears, nose, or penis due to the risk of tissue necrosis secondary to terminal arterial vasospasm in these structures. Okay, remember that. High pressure wound irrigation is more effective in achieving complete debridement of foreign material. So remember that you can use your syringes, right? And then do your high pressure irrigation. In this way, you can remove foreign material and non-viable or devitalized tissues from the wound. You could also use your iodine or your povidone iodine or hydrogen peroxide or other antibacterial preparations in the market. So in general, the smallest suture required to hold the various layers of the wound should be used in order to minimize suture-related inflammation. So you have to use non-absorbable or slowly absorbing monofilament sutures because these are suitable for your suturing, right? For approximating deep fascial layers, particularly in the abdominal wall. Subcutaneous tissue should not be closed with braided absorbable sutures. Okay, with care to avoid placement of the sutures in fat because they will not fat will not take the sutures. Okay, mat-tear lang na siya. Okay, so I guess that's the end of my slides. Okay, so question: the first cells, as a review, the first cells to migrate into the wound are which of the following? Anybody?
PMNs, Doc.
PMNs. Okay, so been 24 to 48 hours. So this one, the tensile strength of a completely healed wound. When does that occur? Approaches the strength of the uninjured tissue. Remember our discussion earlier? Does wounds, right, after healing process, do they return to their original strength? 2 weeks, 3 months, 12 months after, or never? Who will answer? Mula?
Not sure, Doc. 3 months, Doc.
3 months? Nga ikaw lang pero may answer ang iban. Absent? Okay, never. Okay, wala na iya. Okay, it will really not approach or ang iyang healing, ang strength sang tissue will really not approach of the uninjured tissue, the strength of the uninjured tissue. Okay, which layer of the intestine has the greatest tensile strength? This layer should be included really in your sutures or in your anastomosis, because if not,
Doc, good afternoon.
yes.
Try ko lang, Doc. Letter
Okay.
C.
Submucosa.
Yes, Doc.
Okay. The submucosa, correct, is the layer that imparts the greatest tensile strength and the greatest suture holding capacity of the bowel. So you remember that, no? It's not the serosa, it's not the muscularis, not the muscles, but the submucosa. Okay. So that was my last slide. Thank you. I'm sorry, but I'm a bit in a hurry because I have still surgery to do. But if you have any questions, I can entertain 1 or 2 questions.
Doc,
Yes.
like in sports injuries, Doc, that concern tendons or muscles, how do they determine when the wound is when you are able to use those muscles or those muscle groups again?
Okay, like sports injuries.